My reality is that Norm has introduced me as a family physician. I haven't actually done primary care for about 12 years. I joke about going over to the dark side. I work with an amazing, large, actually the largest per capita interprofessional chronic pain team in Canada. I have to say per capita because we only have 100,000 people in Thunder Bay. We treat an area, or we are responsible for a geographic area about the size of France, or 40% of Ontario's landmass. I have no financial disclosures. That said, I'm open to offers. I have no disclosures. As I said, I do warn you, I do improv theater. And when I woke up this morning, I woke up early because of the time change, and actually listened to Robin Williams for a good hour before coming in, so we don't know where this will actually end up. So this is an interesting little interactive device. I always find it's interesting, particularly at this event, to see who's out there. Yeah, I noticed a lot of you are actually using your cell phones rather than listening to me. So if you'd pull out your cell phone and just text Bryan MacLeod 023 to 37607, and then tell us who you are. If you were a person who struggles with either EDS, POTS, or MCAS, then dial in 1. If you are a caregiver or a support person or someone else in someone's life, dial in 2. If you are a clinician, 3. If you're a clinician who actually also fits category 2 or 1, dial in 4. And if you're not sure you're in the right room, dial in 5. See if this actually flies. I discovered the internet system here actually is a series of squirrels in another room carrying messages. So has anyone managed to dial in? So to that number. You can also, if you've got your computer up, you can go to pollev.com/BryanMacLeod023. There we go. We have 1 clinician in the room, which is excellent. We know it works. 2. They were the ones actually not listening to my talk, and were already on their phones, which is why they were up and a little bit quicker. There we go. Keep plugging. There we are. Oh, good point. Well, they should be here. Yes. So sorry, people. They see the slide set as well. Okay. So, but they've got like an open bar in there too, don't they? Isn't that how that's? I heard about that yesterday. I got myself all settled in at this desk, and they were like, and there's comfy chairs, and you can nod off if you want to. And I was like, okay, I'm there. So I was sort of curious to see how this would play out. As we answer here, I was interested certainly from a standpoint of clinicians who get into the business from a standpoint of having front row seats, either themselves or others who might have the condition. I've certainly seen that. We see a lot of people in the pain world who themselves have chronic pain and sort of came to appreciate things. I think what I wanted to point out, and I may move on because apparently the chipmunks or squirrels or whatever are moving slowly. Whoops, hello. So you dial in the number 37607, and then you enter my name with 023. Okay, so my keyword is the Bryan MacLeod 023. It's all good. Okay, I'm gonna move on, but the point being here is I'm gonna direct a lot of our conversation to the big bar at the top. Now, ideally, the other bars will change, right? So hopefully more clinicians in the room over time, which means the message is spreading. I came here 2 years ago, and they had all the desks up front for clinicians, and I sat down in one. Dr. Guzman sat in another. And it was basically the presenters were in the front. It was kind of fun. And then other is 5. Other's choice is 5. I looked up, I'm like, wow, we've actually got 5 people who are like, I'm in the wrong room. All right. So what I wanted to do today was just reflect on a few objectives. One is just teasing apart some of the difficulties, possible challenge with EDS, people with EDS face in the way of best and most efficiently supporting them. Consider common presenting challenges. And consider when all of us need a bit of help in getting support for the condition. This is the complexity of the EDS identified in this conference. This is actually one of the multiple iterations of your final program here. And when you look at the column, it's an intimidating list. This is a bit sort of how I feel, so often by the end of the conference, just trying to process all of the new information which I get. And I'm a physician, and that's often how I feel coming out of conferences like this. Partly my preference for beer, but from a standpoint of there's a lot of information. There's a ton. And when we actually take a look at the reality of what it is to be a frontline physician, I'm not so far away from primary care that I don't remember that. I'm a frontline pain physician, and yet I often feel a lot like this. And this is actually a really good thing, and the theme of my talk as I pulled up this particular slide. It's one of my favorite Fireside comics. It's a little bit, maybe it's blurry, maybe it's not. Those of you who haven't had your second coffee in the morning, I'll read it for you. But the premise here is these guys are playing rock, paper, scissors in the days before scissors or paper. And it feels like basically you've just got rocks. Rocks. And you may have felt this as you have attended this conference and then tried to bring your knowledge and all of your experience to your healthcare provider, and at some level either felt like they just kept throwing their fist out. I don't know, I just got rocks. Yeah, I think it's fibro. I got rocks. Right? Or they early on board, but then aren't sure how to move things ahead, right? So what tools do we have to actually help people? So this one just says, I'm not going to do it all. I want to this is a question that I have found really valuable in my practice working with people with all different types of chronic pain, and I do a very large general practice. I want you to take a second, those of you who figured out how to do this. I apologize, it should be easier. There's a nice app as well, but there's an app for everything. But I just want you to take a minute or two and think of the top 3 words that help you describe the answer in your own personal experience to this question. What's it like having your condition, be EDS, MCAS, POTS, all 3, some of them, in today's medical system? And what words describe your reality at present with your condition? So just text those suckers in. My son's a gamer, much to my shame. We have download speeds of 150 megabytes per second in our house. The chipmunks are turbo. There are no gamers, apparently, at Sick Kids. Oh well, it was a good thought. So let's just do what I do. I don't have this when I actually work with the groups that come to our team. What are your experiences? What's the words? Just let them out. What are the words that describe your current experience? Frustrating is actually one of the most common words that I hear in the chronic pain world. Certainly would fit with my experience of folks chatting with folks with EDS or one of the other comorbid conditions. Other words? Circles? I could... Going around in circles. So there's a bunch of different ways. Does anyone else, first of all, does anyone resonate with frustrating? Okay. And that could have been anyone, right? That could have been those of you who are struggling with the conditions or those of you who are trying to treat them as well, right? So absolutely. Circles may also, and you could interpret that a number of different ways. Randy, right? Hey, I memorized all of your names before coming in here. I'm just that kind of speaker. Your question. Demeaning. Okay. So certainly I hear the word demeaning a lot. I hear the word judged a lot. There's a lot to that particular set of words. I apologize for this. There is no keener group of marketers than Poll Everywhere. I get emails all the time going, how do you like our app? And I'm always like, I can never get the thing to work. It sounds like a great idea. 2 a.m. when I'm making the presentation, I'm like, this is going to be awesome. And then it doesn't happen. So this is my 100 whiteboard. So what I do is I sit down with a blank whiteboard, just a group like you, and I say, tell me about it. And for 45 minutes, they do. And we hear a lot of common themes. So I see, again, people with all sorts of different conditions, but there are a lot of commonalities. Common other words we hear are things like isolating. That it's immensely isolating to have a condition, either because physically you can't get out, Or maybe you're off work, and if you go out, and God forbid you should smile at your nephew's hockey game or something like that, the judgment that follows that. I've learned, and we're not doing this today, I've learned that if you take 45 minutes to talk about how shitty things are, you better take the last 15 minutes of the hour-long chat and build them up a bit again, because it can be really depressing. So we end with the question of, and what's gotten you this far? How have you survived? And we hear a lot of really positive things that people go on to share. And that can be, sometimes it's family, sometimes it is not family, sometimes it is key people in their lives, sometimes it's faith, sometimes it's your pets. So there are very important things that allow us to get this far. Those are important conversations, and there's something I make sure that every one of my medical students who comes through my practice gets an opportunity to access, because it's a conversation that's absolutely essential, and it's not part of medical education at present. So these are some of the words or some of the descriptions which I hear commonly and expect, and was a bit, I did actually type these ones in before arriving yesterday, and was not surprised to hear that they are also some of the words that came up in the survey. But that's not the way that yesterday was structured, the way that today is structured, no matter how all the excellent learning that we are doing, it's not how the world is structured. It's not how people present. People don't come through the door, or they may try to going, hi, I've got MCAS. Okay, you haven't heard of it. Let me explain. But by and large, this is what we see in a general practice. We see someone coming through the door who themselves don't know they have a connective tissue disorder, who just know that they feel broken in a whole bunch of ways. And I've had it fed back to me that actually just the process of going, this could be all your connective tissue disease, is a hugely validating experience for them. It's not about having a million different things broken. It's about one thing that is spread throughout your body that doesn't work as it should. And to actually turn things around, I meant to put up a slide, but I had a young woman, and the talk yesterday resonated with me from a standpoint of her whole life feeling clumsy. And what I want to do is I want at that moment to have a balance beam or a BOSU or something in my office and have their relatives, preferably ones who don't have EDS, to stand on it and have them wobble across this balance beam and go, you're doing that every day. To me, that's pretty damn impressive, right? If you're having to manage this proprioceptive system that has you not quite grounded, no one else has to do that in their day. Their muscles don't have to compensate. They don't have to put up with that. So don't feel, I understand how one could feel clumsy. But man, the flip side is you're navigating something that a whole bunch of people will never have to navigate. Anyway, so this young lady here, a fairly classic kind of presentation. This is more of a hypermobility kind of presentation that I might see fairly often. The fatigue word is one of those words that also comes up a ton, and I don't have to tell that to anyone in this audience. And when you start putting things together, this is also the kind of thing that can be very challenging in a primary care environment from a standpoint of where do you start? And where do you start is often what's the fire that's bugging you the most at the moment. How many people here have had a list of things that they really wanted to talk about, but because of the first couple of fires, and it takes some time, even if you have an excellent primary care person, you never get to number 5 on the list because the next time there's another fire and another thing. That's part of the bugger of this for everyone in the room. Here's another bugger. This is, it's old actually apparently, but I work at the medical school part of my time up in Thunder Bay, Northern Ontario School of Medicine. Strongly recommend it. But this is their curriculum. The way doctors learn is broken down into systems. This is the way they think. And they learn from manuals that are designed for acute presentations, not chronic disease models. Now it's starting to change a little. So I read out of the Bates Clinical Skills Guide in, I won't say when, but it was a long time ago, and they're now at like Bates 20. Bates went for like a decade on one edition, and then got into gambling debts or something, and is now pumping them out on an annual basis. Somebody's related to Bates here, I apologize, it's just joking. But the point being is that it's all broken down into sections. You actually learn musculoskeletal over here, and then neuro over here, and even a back presentation that's not even complicated has to combine the two, but we don't. So here's what you're up against when you come in and your connective tissue is body-wide. It spans all systems. If you've got MCAS, I just started to feel I had MCAS down, and then I spoke with Larry at dinner last night. And it's more complicated than I even thought. There's not necessarily a rash. I was hanging on the rash. So if I told you we'd go there. So this is also what you're up against. They did a survey in 2007 looking at medical clinics who actually, how much do we teach our clinicians, our family physicians about pain? If you take a look up here, in medicine, the average medicine graduate will get 16 hours of pain education in their 6 years to family medicine. Your average veterinarian in their 4 years will get 87 hours in pain. If there's a question at the back, or you're just fist pumping. Are you a veterinarian? You are! That's totally awesome! She was the one, maybe, she was like, yeah! That is the first time, I put this slide up a ton of times, the first time I've ever had anyone go, yeah! So I often say to people, like if you're going to your doctor for pain, you should be going to your vet. I did say this to the medical society in Thunder Bay, and they have not asked me to talk again. But this is a bit scary, right? So when we talk about advocacy, this is just pain, right? Pain is broad, it's huge. 24% of primary care presentations are to do with a pain presentation. So where does EDS fit in those hours? Somebody just goes, EDS, and like it with a book at the front. You don't even see. What? Oh. All right. And then we have things like this. So we do have some tools that we can read on. And again, as a generalist, I'm clinging to these tools. I'm saying, aha! And I'm like teaching my learners, bait and score. And then I went on and read some more. And apparently, this tool was used for research and never validated for a clinical environment. Bugger! It's not the word I said at the time I read this, but I'm like, okay, seriously? So this one is pretty cool because it's validated for a clinical environment. You can use it in your waiting room, and it's one I actually have on my medical history form. It's really useful. Now, it's also a great screen because some people in this room would be filling it out. Yep, can do that. Oh, no, yeah, okay, I can do that. And then you get the ones who don't have any connective tissue problems. They go, what is this question you're asking me? This is, I've got pain. Why would I want to do that? But it's extremely helpful. And part of my pitch here to the people that are far more intelligent in this room, all of you, than I am, is to start looking at these tools and how they can be disseminated to the front lines, right? Give us something other than the rock. So I wanted to talk a bit about the generalist approach. So we need validated tools, and I want to pitch for CAT, and I'll explain what CAT is. So this I didn't ask Larry if I could plagiarize from him. I plagued Tom yesterday going, I'd like the presentations if I could. I have no content myself. I want to use other people's slides. And so this is actually was part of Larry's, thank you Larry, MCAS history taking. And this is his review of systems that he covers. And it's in fairly technical terms. You'd have to make it accessible to anyone who might be reading it. But is there an opportunity to take something like that and create a questionnaire that you could use in your office and then actually, and he mentioned that, I was like, aha, there's one. And he gave the reference. I was like, I'm going to use that one. And then yesterday he said, it's a little out of date. And I was like, oh, come on, really? So do we have something like this? And moreover, do we create it with CAT scanning? So I'm not a CAT person myself. Some people in the room are like, oh. It's not a meme, he's not going to do anything cool. But what's CAT scanning? So what CAT scanning is, and this is based on, there's a model that uses this in the pain world called Choir. Now, when we have people fill out questionnaires for the pain world, it can take like 2.5 hours. If you didn't have a pain condition going into filling out the questionnaire, by the time you're done filling it out, you probably do. So what this actually does is it says, if you answered X to this question, forget these next 20 questions, move to the 21st because that's the next meaningful question for you. And it lets you take a 2.5-hour questionnaire session down to about 20 minutes. Very, very helpful in a way of validating your experience and whatnot. Whew, okay, we're moving. So that's my pitch for that. So what do we do in an educated environment? We want to break things down. So what I want to talk about is, very briefly, is how we break things down into acute, localized problems, how things affect people locally, who have EDS or MCAS, a little harder, who have POTS, and the MCAS and POTS. So this gives you an example. This is my backyard, Thunder Bay. It's my neighbor. So when we talk about EDS, one of the things we find with hypermobility syndromes is if anyone here has gone to a physio and they've said, just stretch it out, right? And you're like, okay, my muscle's in spasm, but I can still do this, and your head goes like this, but the muscle's still tight. So the way I reference that is I talk to people about hammocks. Now the hammock part is supposed to be the muscle part, and the cords off the back in front of the hammock are meant to not give. But your cords give. So you go to stretch the hammock, but when you pull, it's just the cords that kind of give loose. And the bare part doesn't actually move very much. So this is a population. I grew up on saying people should stretch, people should not have passive therapies. You know what? In this population, is something like massage where they actually get in, screw the hammock cords. Yeah, I hear that. If we're doing ischemic compression with using balls against walls, yeah, it works. So we have to recognize how your specific needs are reflected in a local presentation. But the challenge can be, as we saw with this young lady, she's presenting with frequency or with urgency. She's peeing more when she doesn't want to. So is this actually something that's higher up or something that's more systemic? And we have to keep that on our radar as well. In speaking with physicians who are only used to doing systems things, maybe that's part of the conversation. I know this system seems to be out, but it also can be neurological. And so these are anything that's actually meaningful you can get out of other presenters. That my talk, they were saying, we need to videotape you, and I'm like, really, there's not going to be anything worth videotaping. So this is Dr. Henderson from 2015. This is like one of my Bibles. I pull this presentation up all the time. You'll see why in a moment. But he's got some great slides talking about things like C4, C5, and what happens as far as shoulder pain. So it's not necessarily just that your muscles are spasming and you can't stretch them out, but are you actually kinking your spinal cord such that you're getting neck and shoulder pain? Oh, 7 seconds. Sue scares me a bit. I'll be quick. When we take a look at things like mast cell activation syndrome, again, that body-wide piece. And then this was actually the cervical medullary syndrome. I laugh only because I've sent that question to a neurologist. Could this be it? And they were like, what? When I look at this, I'm like, oh, this is complicated stuff. It's one of the reasons I refer back to it, but it's also this idea of being a central problem that can manifest in a bunch of peripheral ways. So this is actually from Dr. Fagfurui, who I don't see here today. Yesterday I said, man, don't ever say yes to Sandy to present at a conference and then have them come out with new guidelines like 2 months later, and then find out at the conference that there's like this whole new guideline in March of 2017 as a generalist. I'm like, no! So last night I bring it up, I'm thinking, okay, I'll read this, and I'll know what I'm talking about. And it's not just that, it's 276 pages long. It took me half an hour to just download it all. I had to buy a special membership at the hotel just to get the bandwidth in order to pull down this sucker, right? So it is complicated. I'm back at this again. I'm almost done, I promise you. So ultimately, it takes a village. And part of one of my realities in Northern Ontario is my relatives are all like, you live where? We're not coming up there at all. So if you don't have relatives where I live, you find them. You adopt a grandparent, you have fictive kin, you build community. And this is shitty in your circumstances for all the reasons that we've talked about. You're tired, you've got pain, people don't get it, you feel isolated. I get that, and I get it as a tourist. I don't have a front row, okay? But finding members of teams and then kind of sticking them together, this is what I do in my work, find people who get it, and then try to bring others in the team on board from a clinical standpoint to be able to fill in some of those gaps. So Sue introduced me to a pelvic floor physio this morning, not strictly because I need one, and I was like, yes, pelvic floor physio, I love it. And she was like, okay, because like doctors don't do that a lot. But from my perspective, and we have one in Thunder Bay who's excellent, she's my buddy, right? Because there's tons and tons of important stuff, and to build that team is really, really key. It's hard to do it alone. So I'm not sure I gave any answers, but I wanted to give that perspective, and if there's any take-home here from anything I said, part of that's going to be thinking about how physicians are trained or not trained, thinking about how we're trained in systems, and you've got a problem that spans your body. How do you then present with both local concerns, but also helping them understand some of the potential broader parts? It's kind of how we think. Hopefully that was a useful 20 minutes.